Seizures can be a frightening experience for patients, their family, and friends, and they can have serious implications for patients personally as well as socially and at work. Seizures are also not that uncommon. The lifetime risk of experiencing at least one seizure is estimated at around 5%. When a seizure occurs, one of the first things to establish is whether or not a patient has epilepsy and requires treatment with an anti-seizure medication. Once it's determined that a patient should be started on medication, there are a vast array of anti-seizure medications to select from, each with different indications, side effect profiles, and the potential for drug-drug interactions.
From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice. Here's your host.
I'm Christopher Muth, Senior Editor at JAMA, and I'm joined today by Dr. Andres Kanner to discuss some of the many factors that go into the diagnosis and treatment of patients with epilepsy. Dr. Kanner is an epileptologist and Professor of Clinical Neurology at the University of Miami Miller School of Medicine, where he directs the Comprehensive Epilepsy Center. He, along with co-author Dr. Manuel Melo Bici, wrote a review article recently published in JAMA about anti-seizure medications for adults with epilepsy. Thank you for joining me today, Dr. Kanner.
Thank you for having me. It's a real pleasure for me to join you.
I think most clinicians and many lay people have a sense of what they think a seizure is. But I wanted to start by just talking about what a seizure is, because in fact there are many different types of seizures and different types of epilepsy. So to begin with, what is the actual definition of a seizure?
So a seizure is what we call a paroxysmal event, a sudden event that manifests with a variety of clinical phenomena that can include motor phenomena, sensory phenomena. Patients may experience visual symptoms, auditory symptoms, psychological symptoms, and these seizures can actually result from abnormal excessive electrical activity in circuits of the brain.
When we're talking about seizures versus epilepsy, can you clarify those two terms and what the term epilepsy signifies?
Yes, so this is a very important concept. The seizure is the individual event that happens. As you said in your introduction, a person may have, in the general population, a risk of 5% of having a single unprovoked seizure in the course of their life and never have another one. The diagnosis of epilepsy is a condition of the brain that predisposes the occurrence of recurrent unprovoked seizures unless you start treatment that will prevent the recurrence. So when you're establishing a diagnosis of epilepsy, you are saying this brain has the potential of generating spontaneous seizures, and that person needs to be treated. You can have a seizure that can result from an acute disturbance. Seizures that are the result of these sudden disturbances would not be considered epilepsy. They would be considered acute symptomatic seizures. And when you take care of the underlying disturbance, the problem is resolved and that person is not at increased risk of having recurrent seizures.
Those would be like provoked seizures then, right?
Those are provoked seizures. On the other hand, the diagnosis of epilepsy is established when you've had at least 2 unprovoked seizures or 2 spontaneous seizures with at least 24 hours apart from one seizure to the other, or if you have a first unprovoked seizure that occurs in the setting of abnormalities in the MRI studies of the brain that show structural pathology in the brain, like brain tumor or like an area of encephalomalacia. So when you have one seizure in the setting of these findings, then you can establish the diagnosis of epilepsy. So an easy way of thinking about it, the seizure is a symptom of the epilepsy.
Now, I wanted to turn and talk a little bit about treatment with anti-seizure medications. There are a lot of things to think about when choosing an initial anti-seizure medication. What are some of the things that go into the initial treatment decision?
So the first thing you have to establish to select the proper anti-seizure medication is what is the seizure type and the epilepsy type, and if the person meets criteria for an epileptic syndrome. Because the type of medications that can be effective in suppressing the seizures in certain type of epileptic seizures may worsen other epileptic seizures. So it is of the essence that the clinician knows what type of seizures and what type of epilepsy and what type of epilepsy syndrome they are treating. The second set of variables that the clinician needs to consider is this person suffering from other medical, psychiatric, and neurologic conditions where the anti-seizure medication can have either a therapeutic effect or an iatrogenic effect, a negative effect. There are several anti-seizure medications that in people with a previous history of mood and or anxiety disorder or family history of these conditions can cause the occurrence of psychiatric symptoms, including symptoms of depression, anxiety, suicidality, irritability, poor frustration tolerance. So those are patients in whom you will try to avoid those drugs. If you prescribe these medication to people who've had a prior history of depression or anxiety or a family history of these conditions, you're going to facilitate the development of symptoms of depression, anxiety, and that can affect the quality of life of this patient.
Important, it sounds like, to get a understanding of any mood problems before prescribing a medication.
Correct. On the other hand, there are several anti-seizure medications that have mood stabilizing and anxiolytic properties, and those are the type of anti-seizure medications that you would select for those patients. Migraine, for example, is common in people with epilepsy. 20% of people with epilepsy and up to 30 may have a history of migraines. Certain anti-seizure medications are effective in preventing migraines, such as topiramate and valproic acid. In those patients who have a history of migraine, you may want to select those anti-seizure medications. The other variable that you need to consider is the medical condition of patients. So, for example, in people who have a history of cardiovascular disease, high blood pressure, diabetes, and who are at risk of coronary artery disease or strokes, there is a whole group of anti-seizure medications that can worsen the atherogenic process. And those are medications that have been used for a long time: phenytoin, carbamazepine, phenobarbital, and primidone. And those are medications that are known to increase serum cholesterol, serum homocysteine, CRP, and they have been shown to increase the thickness of the intima of the carotid artery. And we know that patients exposed to these drugs have an increased risk of developing de novo coronary artery disease or strokes. And so you may not want to use those medications in those patients. In addition, you want to consider if the patient is a woman of childbearing age, and if the woman that you're evaluating is planning to become pregnant. In those cases, you're going to have to select anti-seizure medications that have been shown to be safe if exposed to the fetus in the uterus, because certain anti-seizure medications can cause significant teratogenic effects in the fetus.
Very helpful. I think another special population to think about is older adults. Oftentimes, they're already on several other medications for other comorbidities, some of which can affect their cognition or put them at risk for polypharmacy and medication side effects. What kind of important things to think about for prescribing anti-seizure medications for older individuals?
The incidence of epilepsy increases as people get older. So somebody who is above the age of 70, 75 has a significantly higher risk of developing epilepsy than somebody who is 30 years old. Most people, if not all people who develop epilepsy in this age group suffer from focal epilepsy. But as you said very correctly, a big percentage of these patients are taking concomitant medications for comorbid conditions. The average person who is 65 years and older takes a mean of 7 non-anti-seizure drugs. And when you select your anti-seizure medication, you have to ask the following question. Is this anti-seizure medication going to have any pharmacokinetic interactions with the other medications that the person is taking? So, for example, there is a whole class of anti-seizure medications that are known as enzyme-inducing anti-seizure drugs, and that includes carbamazepine, phenytoin, phenobarbital, primidone, and then topiramate at doses above 200 milligrams and oxcarbazepine at doses above 900 milligrams can also have those properties. What these drugs do is they accelerate the metabolism of concomitant medications that are metabolized by common cytochrome P450 isoenzymes or common metabolic pathways. And by increasing the metabolism of those drugs, you're going to limit their efficacy because the serum concentrations will drop. So, for example, a person who is taking a statin that is metabolized by the same cytochrome P450 than phenytoin or carbamazepine, the metabolism of that statin is going to be increased by 50%. So unless you adjust the dose of the statin, the efficacy of that therapy is going to be decreased significantly, and the person is going to have problems with their lipid profile. Very often we see patients with high blood pressure that is not responding to their therapy because they are being treated with concomitant anti-seizure medications that accelerate their metabolism. The other question you have to ask yourself is, does this anti-seizure medication have a pharmacodynamic interaction with concomitant medications that can cause problems? So, for example, if you're using medication like carbamazepine or oxcarbazepine, which are known to cause hyponatremia, and the person is taking a diuretic medication for the treatment of their high blood pressure, you're putting that person at increased risk of developing a more severe hyponatremia. Those are common considerations that you have to think about.
In a lot of cases, it'll be the neurologist that may be selecting the anti-seizure medication, but the general medical practitioners will be monitoring for a lot of these side effects or be needing to be aware of many of the different drug-drug interactions with a lot of the medications that are used to treat medical conditions.
Exactly. And it's very important that if the person is being evaluated by a neurologist and given anti-seizure medication, that he or she communicates with the internist or primary care physician in explaining what potential pharmacodynamic or pharmacokinetic interactions could be expected from the use of medications necessary for the treatment of comorbid conditions so that these problems can be avoided.
And then in terms of the goals of therapy, what is the goal?
The goal of therapy is to obtain a complete remission of seizures with minimal or no adverse events of the medication. Because persistent seizures, if you continue to have seizures, you are at increased risk of self-harm such as fractures, injuries, concussions, contusions, and you have, if you have convulsions in your sleep, an increased risk of death by what we call sudden unexpected death in epilepsy. You can also die from drowning. Therefore, the goal of therapy is no seizures. Also, in the past, it used to be considered that having one seizure every 6 months or one seizure a year was an adequate control. Today, that's not acceptable anymore. Why? Because if you have one seizure every 6 months or one seizure a year, you cannot drive and you cannot do many of the things that you need to do in today's modern world. And also because you're still at risk of self-harm, as I mentioned before. Today, we consider that if you have been treated with 2 optimal trials of anti-seizure medications, If you continue to have seizures after 2 optimal trials, that is, that you are on the right medication at optimal doses, and you continue to have seizures, you probably are going to have what we call treatment-resistant epilepsy. That means that medications may not stop your seizures completely. And in those cases, you may need to be referred to an epilepsy center in order to establish the following things. First of all, you need to make sure that the diagnosis of epilepsy is correct, that you actually, in fact, are suffering from epilepsy, and that the medications that you have been treated with are the proper medications for the type of seizures that you have. The reason for that is that 1 out of every 5 people that are referred to an epilepsy center with a diagnosis of intractable epilepsy do not have epilepsy.
What are some of the epilepsy mimics that people need to be thinking about?
The most frequent epilepsy mimics are the convulsive syncope. That is often misdiagnosed as a convulsion, and people are erroneously diagnosed. There are psychiatric disorders, what we call psychogenic non-epileptic seizures, that often mimic epileptic seizures, but in fact are non-epileptic events, and those are among the most frequent imitators of epileptic seizures. And then you can have certain type of movement disorders, sleep disturbances, such as people with narcolepsy can have cataplectic events that are often misdiagnosed as epileptic seizures. Certain type of migraines can also be misdiagnosed as epilepsy, and certain type of vascular events have to be considered.
Okay, thank you very much, Dr. Kanner. In summary, there are several different types of seizures and different types of epilepsy. When selecting an anti-seizure medication, consideration should be given not only to the seizure or epilepsy type, but also to any patient comorbidities and drug-drug interactions. And it's important to treat seizures with the goal of completely eliminating the seizures while minimizing adverse effects of anti-seizure medications if possible. I'm Christopher Muth, Senior Editor at JAMA, and that's all for this episode of JAMA Clinical Reviews. A special thank you goes to Dr. Andres Kanner. This episode was produced by Shelley Steffens at the JAMA Network. The audio team also includes Jesse McQuarters, Daniel Morrow, Lisa Harden, Audrey Foreman, and Marilyn Ferkaluk. Dr. Robert Golub is the JAMA Executive Deputy Editor. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.